As a healthcare investor, I'm particularly excited about this next conversation. We have Allon, Bloch, who is the co-founder and CEO of K Health, which is a clinical AI primary care company on the mission to get everyone access to high-quality, affordable healthcare. Previously, he was the co-CEO of Wix and also the co-founder and CEO of Vroom. He's raised over $2 billion from VCs, private equity firms, and corporations all across the world. And we also have Katie Jennings, who's a senior writer of Forbes, where she covers healthcare and technology. She was previously at Politico and was a Knight Bagot Fellow in Business and Economics at Columbia University. Come on up.
All right. I hope that everyone enjoyed their lunch. Now we're going to dig into everyone's favorite topic, artificial intelligence. So for people who aren't familiar with K Health, so the patient comes in, they start having a conversation, but it's essentially with a chatbot that's going to start asking them a lot of questions until the chat is then passed off to a human doctor. So Allon, you started building this 7 years ago, long before the ChatGPT craze. But can you explain to us how what you're building is different than what we're hearing about with all of these LLMs?
Hi, everyone. It's great to be here. And also was Primary Ventures. They backed me in the seed round. It's good to see just this huge event. I would say AI is not a new concept. Large language models as a product in ChatGPT are. They still have a basic problem. They hallucinate. And when I raised money when we started in 2016, 2017, I said, everybody's got these health questions and people have big and small problems, acute issues, chronic issues. But we have this acquiescence to really bad information. It's called Dr. Google, it's called WebMD. It's not helpful, it's scary. If you don't have diarrhea and you use WebMD, you're gonna have diarrhea because it's gonna scare you.
True.
Medicine is complicated. You have false positive, you have false negative. You don't wake up in the morning and do a lab test. It's this really tricky profession. Doctors speaking big words in Latin, so if you're not a doctor, it's like going to a priest. It's scary, you don't really know what they're saying. I wanted to demystify this in a way that Dr. Google didn't. So we built predictive models. They try and mimic differential diagnosis and treatment. They take into account the patient, their history, their symptoms, their gender, their age, their ethnicity, all the things that doctors do to make decisions, and we used real clinical data. We didn't use Reddit data. We didn't use random form data. We didn't use the internet. We used clinical data. It includes data that we got from an HMO in Israel. We use data from Mayo Clinic, and we now use our own patients' data. We've seen 3 million patients. That is very different from ChatGPT. And I'll just give you one example from my perspective that gives you a sense of the difference. Because ChatGPT is an amazing capability engagement, and everybody knows that, and everybody's listened to all these articles and read all these posts, etc. But it still hallucinates. Nobody wants to go to a doctor that hallucinates. And in that respect, it's the same as Dr. Google. If you went to a doctor and you knew that that doctor 20% of the time made up stuff, because they had some kind of mental model that made up stuff, I doubt anybody would want to go to that. And so ChatGPT at its current form, and I'm not picking on ChatGPT, so all LLM foundation models are not closer to being a doctor than Dr. Google is, which, again, Dr. Google is not a doctor. So we're always attempted to build a machine that understands medicine, can engage with patients, can engage with doctors, in a way that is clinical grade.
But so when you say that K's models don't have this problem of hallucination, I mean, they can't know the answer all the time. So what happens instead?
That's a very good thing. A very good point. About 20% of the time, doctors don't know the answer. Patients always think doctors know the answer or have it in their head. But roughly 20% of the time, doctor diagnoses NOS. Tinnitus is ringing in the ear, general abdominal pain. Those are real diagnoses that doctors give. They might be temporary, they might be they just never found out. Doctors have a duty to say, I don't know, or I need you to, time needs to pass, or I need to send you to do certain tests. That's very different from ChatGPT. ChatGPT is never in doubt, often wrong. And again, not ChatGPT. Choose your foundation model. It's trying to answer. It doesn't care if the answer is right or wrong. So it's very different. I'll give you one intuitive example that I think that and I think I told you this a couple months ago, but you might have a lot of questions about sushi. And you go to ChatGPT and you want to know the best restaurant in Tokyo to have sushi, hero dreams of sushi, why is it so expensive, health risks of raw fish, et cetera, et cetera. And ChatGPT can give you a lot of different answers that are, maybe helpful, maybe not helpful, but, they're going to give you a lot of information. Our AI also cares about sushi in the context of raw fish that a 35-year-old female just ate raw fish 4 hours ago and has abdominal issues and is not pregnant and maybe has thyroid issues or other issues and is vomiting or nauseous. We're not trying to solve all the problems in the world. We're trying to focus on medicine and healthcare in the context of care delivery. That has not been done. And contrary to what most people believe, doctors do not have at their fingertips magical data sets that are every one of us that take into account our gender and age and medical history and ethnicity and are quite specific around diagnosis and treatment. They don't have anything close to it. So it's about time we build it.
So you're going to give the doctors this magical data set, but where do you see this going? Because as we've had this conversation around AI in medicine, I think people are scared. Doctors are certainly scared of, are the machines going to take over and start running things? So where is this headed, and what's the role of K as this into the future?
So I think it's kind of a big problem. It's a $4 trillion problem. I just saw healthcare is slightly bigger than the Japanese economy, and it's on the way to probably being bigger than the Chinese and American economy at the rate it's going. We're not going to solve the problem on our own because it's too manual, too expensive, populations are aging, and medications are more expensive. So you need to be inventive. You need to think of trade-offs, and how would you resolve it if you built medicine today? Medicine was created, late 19th century. And there's a lot of things that doctors practice that are 50 or 100 years old. I think it's time now to think of true automation. And I'm not talking about pre-authorization and summarizing medical chats and all that stuff. I'm talking about true clinical automation that is used in a clinic, at a hospital, at your doctor, whether I'm doing it or somebody else is doing it, based on very detailed data that can work for you, the patient, the human, 24/7, and in certain cases going to be better than doctors.
But so when you're talking about true automation, you're talking about we're taking the doctor out of it, I can interact with the AI, and then the AI will be able to prescribe me a medication.
I will answer it in the following way. There's probably in the next 100 years always going to be room for doctors. There are just too many decisions that doctors need to make in certain areas of medicine. But can you automate migraines, sinusitis, conjunctivitis, UTI, all the way to automatic prescription? I think so. And I don't know of anybody who has a routine, say, migraine or sinusitis, if it was done in a high-quality manner at 10 p.m., that want to go to the ER or urgent care and not get an automatic prescription if it was truly high quality.
But so what does it take to get there? Because right now, there really isn't much of a regulatory framework. This is all kind of new territory. Does there have to be a certain percentage concordance, accuracy? Like, how is this going to go?
Well, first of all, accuracy and quality mean different things in different part of medicine. So there's not kind of one single metric in evidence-based medicine. But clearly, for the FDA, you need to be non-inferior than a doctor. I think in order for us to be able to take a prescription given by a machine, which I think will happen in the next few years, it would need to be vastly better than the level of mistakes that doctors make. Look, Johns Hopkins just ran a big study 6 months ago. It was published all over that they looked at diagnostic mistakes in the ER, which are easier to spot than primary care. And 6% of the times, doctors made a mistake. So that sounds pretty high to me. I would rather see 0.0001, like, level of mistakes, and I think it's doable. So I think in certain conditions where you've got a lot of data and you can do proper rule out and you can consider all the potential diagnosis, not only diagnosis, also treatment, different dosages, what else are people taking, I think you can build systems that are better. I think it will be done with doctors. It will be done with academic institutions. And we're working with Mayo Clinic. We're publishing a peer-reviewed study that's coming out soon that shows that our AI is clinical grade. It's not in everything. Medicine is many worlds. But I think if we want to be serious about taking down the cost of healthcare, and by the way, also improving the quality in America, and if we want to be serious about enabling doctors in places like Africa, Latin America, Asia Pacific, then you need to start using technology at the point of care and have that part of the care delivery models.
So, but a lot of what we're seeing now is it seems like these race, and so this is among LLMs, but about passing the US medical licensing exam. And I mean, what does that actually tell us about how good?
Nothing. It's bullshit. All these studies out there that every one of us, by the way, could pass a medical exam, and it's not going to make you a doctor. Nobody should go to a doctor who just passed a medical exam and has no practical understanding of medicine. For starters, patients didn't read the medical books and might present different symptoms than appear in the medical books. And so I think it's misleading to have those studies unless you caveat it by, hey, we trained a LLM to pass a medical exam, but it's not a doctor.
Okay, but now I want to go back to the study that K-Health has been working on with the Mayo Clinic. So, I mean, if I'm remembering correctly, it's something around 86 amount of time that K-Health's AI is agreeing with human doctors. 86 is not 99.99999. So how are you going to take what you learned from that study and bring it into your business? How are you going to get K to 99.999?
So first of all, doctors agree with each other about 70-80% of the time. And we also brought in adjudicators that showed that external adjudicators agree with our AI no less than agreeing with human doctors. So in terms of clinical validity, people need to remember when you go to a doctor, the doctor, if you went to two random doctors that agree with each other 70 or 80% of the time, not 99.99% of the time. So consistency, and again, let's separate between some advanced oncology treatment, last resort, Mayo Clinic, Sloan Kettering was the average primary care visit for somebody who has diabetes, who wants to avoid diabetes, and he's taking 4 other medication and also has an earache or a headache. Most of our doctor visits are what I described, and not this heroic kind of last resort Mayo in Cleveland. And that's where, by the way, American healthcare is dramatically better than other places. There's more money that goes into these top academic institutions, and that's where a lot of the drugs are developed. But I think that you have to build reinforcement learning. This is where AI, it needs to learn from the data. Essentially, our doctors are training our machines to be better. But it's not it's not a zero-sum game with doctors. I would like to make doctors just dramatically more efficient. When I order pizza, hopefully I'm not calling the pizza place, why are you here? I want to order a pizza, what size? I wanted pepperoni or olives or whatever. I've got a special bundle. Hopefully you use DoorDash or something. So why, when you go to the doctor, you're saying, why are you here? My head hurts on the right side only in the morning. It's radiating to my neck. I didn't lose my appetite, et cetera, et cetera. Like, a machine can do that. And a machine has a lot of patience. It's not rushing. It never had a long day. It can work 24/7. And then we work with doctors very closely. We employ about 150 physicians. We have a 24/7 service. But again, we're trying to build care delivery that also remove costs out of the system. To remove unnecessary forms, remove unnecessary information, and then also learn from the data.
And so the little time we have left, I know recently you entered into a partnership with Cedars-Sinai. So can you tell us, I mean, what are you bringing to hospitals?
Well, first of all, the hospital is bringing a lot to us. And I prefer the term health systems because if you look at Cedar or Mayo, these are large organizations that have multiple locations, they have primary care, they have specialty care, they have labs, tests, everything. And so we have access to their patients, and we can work there, which is, to me, is incredibly humbling. What we're bringing them is the ability to expand their great medical services and enable 24/7, enable them to do primary care at a cost-effective way, enable them to integrate into their systems. We work with the medical data that the patients have, so it's not an urgent care system that's an appendage to the hospital. We are managing patients, in these type of settings, and that's the last thing I will say. Maybe we spoke a lot about technology, but most of the digital health companies that started did urgent care. You need a prescription. It's regulated. It's like an e-commerce funnel. I'll put a doctor. I'll give you a prescription, which is fine for hair loss. I'm not against it, but medicine is not an e-commerce funnel with a doctor, and it needs to be treated very differently. Everybody says, I want to go to my doctor. I want her to know me. I want to have a relationship. Most primary care is not that. People go ad hoc and do urgent care. They're kicking us out. So to me, if you can build systems that are truly primary care in the way that we want to do, but most of us don't do, that actually manages people differently. And it's most important in avoidance of chronic conditions, heart, diabetes, certain cancers. That's where I don't think things have changed in 40, 50 years.
All right, that's all we have time for. Thank you, Allon.